Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Hello, welcome to today's presentation, Heart Attack, Symptoms and Prevention, presented by Dr. Rohit Sehgal, Cardiologist with Washington Township Medical Foundation and Chief of Cardiology with Washington Hospital Healthcare System. And now, please welcome Dr. Sehgal.
Hi, my name is Dr. Rohit Sehgal, and I'm a cardiologist here at Washington Hospital in beautiful Fremont, California. Welcome and thank you for joining us for this presentation. I'm here to talk about a scary topic, a heart attack. The very word conjures up fear and sends chills down our spine. I'm here to talk about it, tell you what it is, how you can recognize it, and most importantly, how we treat it and prevent it. I hope to demystify it for you and show you that a heart attack is treatable and not synonymous with certain death. What is a heart attack? A heart attack occurs when there's a sudden blockage of a coronary artery. Coronary arteries are the arteries that supply blood to the heart muscle, and when these arteries get clogged and suddenly blocked, some of the heart muscle begins to die. This is an immediate occurrence as the artery gets completely blocked, and without medical treatment, this condition would be permanent and cause major damage to the heart. Here's a little drawing that illustrates this. These are the arteries that run on the surface of the heart. Here's a clot forming in the artery, causing the heart attack. And this little cartoon here below is the EKG, which is the telltale investigation, or which is the technology that helps us to determine that a heart attack is occurring acutely. The heart is a muscular pump, and like every part of the body, it needs a continuous supply of oxygen. It gets this oxygen from the little arteries that run on the surface, the coronary arteries that we talked about. As we get older, in some of us, the coronary arteries start to build up fatty deposits in their inner lining. We call this plaque. These fatty deposits or plaques in the arteries sometimes suddenly crack. They get inflamed, they crack, and blood cells and proteins in the blood start to form a clot around that crack, and that blocks the artery and causes the heart attack. Here's the drawing that again shows that, and you can see this clot forming. This is the area of plaquing in the artery, this yellowish substance in the inner lining of the artery, and you see this blood clot blocking the artery. Coronary artery disease is the term we use for this plaque buildup in the inner lining of the arteries, and this is the number one cause of death around the world. The signs and symptoms of a heart attack are variable. Not all heart attacks begin with a sudden crushing pain like you'd see in the movies. Sometimes people have more subtle symptoms. And there are some people who don't have any symptoms at all, which is called a silent heart attack. And their heart attack is just later detected when they go for a physical exam or an EKG or a checkup. The pain with a heart attack is still the most common symptom of a heart attack. The symptoms of chest pain with a heart attack usually last for about 10 minutes and are pretty unrelenting and severe. They can spread to the throat, the jaw, down the arms. It's been described as an elephant sitting on my chest, a red hot poker in the center of my chest. Sometimes these symptoms are not as dramatic. They can consist of a choking feeling in the throat. The arms may feel heavy or useless. The big point of distinction is that these symptoms are continuous and not brief. There's another condition called angina, which is a brief, reversible chest pain that people with clogged arteries will sometimes get. The big difference is that the angina symptoms are brief, are reversible, and usually will occur when you exert yourself, and when you rest, these symptoms will go away. Now, angina that changes its pattern or starts to get more frequent is sometimes a sign that a clot is building up in an artery, and you should seek medical attention for that right away. Again, as we talked about, the heart attack pain is more persistent, more prolonged. It's usually lasting for a significant amount of time. If you find pain that's not relieved within the first 10 minutes or so, you can imagine that this is possibly a heart attack in evolution. Women have more subtle symptoms. They can have symptoms that are a little more hard to pinpoint. They can have nausea, lightheadedness, or just feeling fatigued, sometimes as a presentation of a heart attack. So, unexplained symptoms of feeling nauseous, breaking out in a cold sweat, even if it's not always related to chest pain, or even if it's not occurring with chest pain, can sometimes be a warning sign. Now, this guy, of course, turned out to be lucky. He's more of a outlier, where he had chest pain with this hot melted pizza cheese. But in general, unless you've really, poured hot cheese on your chest, if you start getting a burning chest pressure, it's time to take note. How common are heart attacks? They are very common. In the US, someone has a heart attack every 40 seconds. So in about the time it takes to see this slide, somebody around the country will be having a heart attack. Anywhere between 800,000 to 1 million people roughly in the US have a heart attack every year, and about 1 in 5 of these is silent. And the silent ones in some ways are even more ominous because there's no immediate symptom that leads to people seeking medical attention. So some of them, unfortunately, can present with a sudden cardiac arrest or sudden cardiac death as the first presentation. Those, of course, are not truly the absolutely silent heart attacks, but they are heart attacks where there is extreme electrical instability of the heart causing a cardiac arrest. The purely silent heart attacks will just leave heart muscle damage, but no immediate symptoms. Cardiovascular disease, including heart attacks, sudden death, are the leading cause of death in men and women. About 1 in 4 of all deaths occurring are from cardiovascular disease, and anywhere between 600 to 700,000 people die from heart disease each year. Since 1900, cardiovascular disease has been the number 1 killer in the US every year. except for 1918 when there was the big flu pandemic. Even with COVID these days, cardiovascular disease is still the number one cause of death. A heart attack is also called myocardial infarction. So let me get into a little bit of the technicality of this so that if you ever encounter these terms, you'll know what we're talking about. Myocardial infarction, the term comes from myocardial, which means the heart muscle. Infarction means death of the muscle from lack of blood flow. That's where the term myocardial infarction or MI comes from. Based on the EKG pattern, there's two broad types of myocardial infarctions. There's one called the STEMI, which is based on the EKG pattern. STEMI stands for ST elevation myocardial infarction. These are the more lethal types of heart attacks. They're caused by a complete blockage of a coronary artery. The heart muscle is immediately going to start dying over the next hour or two, and the treatment necessary is an immediate emergency angiography and stenting, basically unclogging that clog. It's kind of like a fancy plumbing job, unclogging that artery and treatment with medications. That's the most lethal type of heart attack, and it's called a STEMI. The non-STEMI is the other kind, which is a partial occlusion or partial blockage of a coronary artery. Some flow is still getting through. So the treatment for that is initial medications, blood thinners, and then angiography to outline the arteries, and then stenting or bypass surgery depending on the amount of clogging seen and the number of arteries involved. Basically, with the lethal heart attacks, with the STEMIs, a lot of research over the last many years have shown that if you can open the clogged artery within about 90 minutes of the patient reaching the hospital, the chance of death is reduced from about 20% down to about 4 to 5%. So that's a huge difference, meaning if the artery can be opened up, your mortality or risk of death goes down markedly. So, as you've seen, a heart attack starts with the artery getting clogged, the heart muscle starts to die, so time is really of the essence. If you start getting symptoms that are suspicious for a heart attack, if you get this unrelenting chest pain, pressure in your chest, breaking out into a sweat, call 911. Don't have a family member drive you. Don't think of getting into a car and driving yourself to the hospital, because you need emergency help right away. The ambulance crews and the paramedics and EMTs will do an EKG and get the cardiac team activated even before you reach the hospital. Once you get to the hospital, the faster the artery is unclogged, the better the survival rates. We use a term called the door to balloon time, and our goal is to have this less than 90 minutes so we can get the most survival and save the most heart muscle. How do we do this? A catheter or a small tube is inserted either in the wrist or in the groin. Under X-ray, we thread this up to the heart, and as I'll show you in this drawing here, we pass a wire across the clogged artery, advance a balloon over that wire, and deploy a metal coil called a stent, which opens up the flow in the artery. And this is how we do it. All roads lead to Rome, so to speak. So the arteries all over the body lead to the heart. We take advantage of that fact, and we either go from the groin, from what we call the femoral artery, which is the artery here, or we go from the radial or brachial arteries up to the heart, and then take X-ray pictures of these arteries where we can see the blockage, and then try to open this up with the stent. This is done in a specialized room called the cardiac cath lab. It's a room with a lot of X-ray cameras, folks with masks and gowns, and nurses and technicians, a whole team working with you. To try to get this system of opening these clogged arteries done as expediently as possible, there is a designation of what are called STEMI receiving centers. These are hospitals that specialize in treating patients with this lethal type of heart attack and unclogging the arteries within the narrow time frame or narrow time window to save the heart muscle. So the STEMI designation is a designation by the American Heart Association for hospitals that can open this artery up within 90 minutes and try to get a good outcome. So you would be happy to hear that our local hospital, Washington Hospital, is a STEMI hospital. We have a robust STEMI program with an interventional cardiologist trained in emergency intervention on call 24/7. We have cath lab nurses and technicians on call. And our outcomes and quality metrics are monitored by the American College of Cardiology national database. On a more personal level, I can tell you that when we're on STEMI call, when I'm on STEMI call, which I take as well, I sleep very lightly. I have my cell phone by my bedside. I sleep in a separate room so that I don't wake up the rest of the household. And I'm ready to leave home in 10 minutes or 15 minutes as soon as I get the call that somebody with a STEMI is there. Here's a patient I did. This was a few weeks ago. A gentleman in his 60s who came in with a heart attack. This is the little tube that I've inserted from the groin. It's called a catheter, and I'm injecting dye into this artery. Here's the clogged artery. This black thing is the X-ray dye hanging up in the artery because the artery is clogged and there's nowhere for it to go. I passed a wire down this artery, passed a balloon and a stent, and lo and behold, here's the artery open with good flow through the artery, and the patient's chest pain resolved almost immediately after the artery was open, and he left home. He left for home in about 3 days or so. He was discharged from the hospital in about 3 days and is currently doing well. How do we prevent this very dramatic heart attack and this whole scenario of, the clogged artery and opening it up and so on? Obviously, it's much better to be able to get to the root of the problem and prevent heart attacks rather than, having to go through that fairly arduous treatment. So the process is to recognize and treat coronary artery disease. The clogging in the arteries that predisposes to heart attacks is what we need to prevent, and hence we can catch the problem before the heart attack occurs. This is a little drawing showing clogging in the artery. Now, to be absolutely honest, we don't know a one single factor that causes coronary artery disease or plaque buildup in the arteries or atherosclerosis. Here's clogging in the artery. This is in the right coronary artery. This is what it would look like in a three-dimensional image or in a pathological specimen. Here's how we see it in the angiogram. This is the catheter with which we are injecting dye, and the dye outlines the artery. It's kind of like a luminogram. We're seeing the lumen of the artery narrowed, and that's how we plan out treatment strategies. So as I mentioned, we really don't know the one cause for coronary artery disease. We have a constellation of risk factors that we can identify, including high blood cholesterol, high blood pressure, smoking, obesity, lack of physical activity, diabetes, and a family history as well. So there's a strong genetic component, and that genetic component obviously goes into many of these other factors like high blood cholesterol, high blood pressure, diabetes. And here are some of the tests we do to try to recognize this, starting from simple blood tests like a cholesterol panel, a blood sugar to check for diabetes, an electrocardiogram, an echocardiogram, which is an ultrasound of the heart, a treadmill stress test, CT scans to look at the arteries of the heart, and our final kind of gold standard, which is cardiac catheterization, which is the process of inserting these little catheters up to the heart arteries, injecting dye, and taking pictures of the arteries. It's also called an angiogram. Angio coming from the Greek word for blood vessel, and gram meaning to measure, so an angiogram or angiography as we call it. How do we treat coronary artery disease? Meaning how do we treat this clogging in the arteries and try to prevent it from reaching the level of causing a heart attack? Lifestyle and medications. Those are the two big things that we start with. Some people who have severe coronary artery disease at an advanced level will need stenting, which is the technique we talked about for emergencies, but stenting is also done in a more elective or planned fashion for arteries that are severely narrowed but not 100% blocked. And this is again done like we talked about, putting in a catheter from either the groin or the wrist, threading it up to the heart, passing a wire across the blockage, and then threading a balloon catheter carrying a coil across that blocked artery and opening it up. Angioplasty is another way of opening up the artery with just a balloon itself. And then we have a variety of techniques in patients who have a lot of calcium deposits. We'll sometimes use a rotating burr called an atherectomy catheter, a cutting device, laser device. So there's a bunch of tools to open up the clogged arteries. In some individuals where they have very extensive disease, bypass surgery is necessary, where the surgeon takes blood vessels, he takes strips of blood vessels from the chest or the legs or arms and creates new conduits which allow blood flow across the blockages. The key thing, of course, before we get to all of these advanced forms of therapy is to try to prevent coronary disease. How do we do that? We get regular medical checkups, control your blood pressure. That's a major risk factor. It's kind of the silent killer because sometimes there are no physical signs from high blood pressure. So get your blood pressure monitored regularly. Follow up with a primary care physician who will check your blood pressures. Get your cholesterol checked. Don't smoke. Exercise regularly. When we say regular exercise, the American Heart Association recommends that cumulatively you get about 2.5 hours of regular aerobic physical activity every week. So you can do a half hour, 5 days a week, do 20 minutes every day, but try to build regular exercise into your schedule. Maintain a healthy weight. eat a heart-healthy diet. A heart-healthy diet is a diet which is low in saturated fats, is calorie controlled, is rich in fiber with fruits and vegetables, whole wheat, whole grain, and lean meats and fish and chicken. Manage stress. Stress is kind of like a silent killer that follows all of us around. It's now clearly been shown that stress causes blood vessels to become more sticky. The plaque tends to ulcerate with stress. So managing stress is really important. Physical exercise helps. Meditation helps. So it's really important to manage stress. In terms of medications, I would be remiss if I didn't go over some of the crucial medications. And statins, which is a class of cholesterol-lowering medicines. You've all heard of drugs like Lipitor and Zocor. These were the original name for the statins when they were brand name medicines. They're also called atorvastatin or simvastatin or lovastatin. This is the category of drugs that reduce cholesterol. They started out as just as cholesterol-lowering drugs, but now we've seen, and a lot of research has shown, that they also reduce inflammation in these plaques in the arteries. They reduce the risk of plaque rupture and clot formation in the arteries, and they've clearly been found to reduce the risk of heart attacks and strokes. And this has been seen in a variety of population groups, in diabetics, in non-diabetics, in people with high blood pressure, and people with normal blood pressure. So they've really been shown to reduce the risk of heart attacks and strokes. And the big question now is, who should be on a statin? In some countries, actually, statins have been made over the counter, so as much of the population can be on a statin as possible. Here in the US, statins are still is still a prescription drug, but the indication for statin use has been quite widely increased, and appropriately so in my mind. We now use statins or prescribe statins not just based on a cholesterol absolute number as we used to in the past, but now we go with a risk assessment. So the concept being, the higher your risk for a heart attack or a coronary event, the more benefit you would get from a statin. So basically, people who have established coronary disease or vascular disease, people who've had a heart attack, a stroke, or have had stents in the arteries or bypass surgery, they should all be on statins. People who are diabetic should be on statins because diabetes increases the risk of coronary artery disease. Some of the new research suggests that even pre-diabetics should be, have that increased risk of coronary disease and should be on a statin. Now, another assessment we use, which is now fairly commonly used, is that people who are not diabetics, who don't have coronary artery disease, there is an online risk calculator, and you can all go online and actually do your own score as well. I've got it up there on the slide. It's www.cvriskcalculator.com. It's kind of an online risk calculator where you plug in some of your parameters and numbers, and it gives you a 10-year risk of a cardiac event. Data shows that if people have an over 7.5% risk, meaning that once you plug in these statistics, if your risk for a cardiac event over the next 10 years is greater than 7.5%, you would be a candidate for a statin. And lastly, because this cardiovascular risk calculator is not absolutely perfect, another tool we use in somebody who has a strong family history, who has risk factors, we do a screening CAT scan to look for coronary calcium. It's called a calcium score. So if your calcium score is greater than 100, it's an indication for a statin. This coronary calcium score is a relatively easy test to have. It's a low radiation CAT scan. The amount of radiation is about equal to a mammogram. It's a relatively inexpensive test. Costs anywhere between $75 to about $250 from hospital to hospital. And it's another tool to use to see if your coronary risk score is sufficient to warrant being on a statin. Another big medication or another issue is aspirin. We used to use aspirin pretty widely. It was an aspirin a day keeps the doctor away kind of thing. Now we've found that the risk of aspirin is not entirely minimal, meaning aspirin is not totally benign. There are some people who will have gastrointestinal bleeding or ulcerations caused by aspirin. So we are a little more circumspect, a little more selective in who should be on aspirin therapy for heart attack prevention. It's still totally recommended for somebody who has had coronary artery disease. Somebody who's had stents, who's had a previous heart attack, strokes, should be on a low dose 81 milligram aspirin. The other big group is people who have a high risk score. So again, the same online cardiovascular risk calculator, if it gives you an over 10% score, you should be on a 81 milligram low dose aspirin. Currently, it's been recommended that people over age 70, unless they have established coronary artery disease, not be put on low dose aspirin for primary prevention because their bleeding risks go up. And here's my favorite spot in Fremont. This is our beautiful Lake Elizabeth, which is a lake in the center of Fremont, which is a wonderful place to walk. And this is where I personally like to get my 2.5 hours of exercise a week, anytime I can. With that, I will leave this open to questions and see if you have any questions that you would like to ask.
Okay, great. Thank you, Dr. Sehgal. We do have a few questions. The first question is, if I am having chest pain, how long should I wait before calling 911?
I would generally say that if your chest pain has been persistent for more than 10 minutes, it's time to get medical attention and to call 911. Remember, it's better to overcall than undercall. Even if we have 10 false alarms, because you definitely can have chest pain from acid reflux, from inflammation of the lining of the chest. So there are other causes of chest pain other than a heart attack. So some of them might turn out to be what we call non-cardiac or not the heart. But it's better to overcall than to miss one major heart attack. So I would say if the pain lasts for more than 10 minutes, call 911.
Great. The next question, my family has a history of coronary artery disease. Can I reduce the chance of having it?
Absolutely. That's a great question. That is so pertinent. Some of the factors we talked about with exercise, diet, getting your cholesterol monitored, avoiding smoking, getting regular checkups, and being on medications if you need them will definitely change that risk. And even though you may have a genetic tendency, these are all modifiable things, and certainly by following all those guidelines, you can modify that risk.
We have another question regarding statins. Are there side effects when you're taking statins?
Sure, there are side effects with statins. You know, like all medications, it's a double-edged sword, and that's why we are, careful about who we prescribe them to. I would say that the side effects are relatively rare and are relatively uncommon. Two broad categories of side effects. One is a alteration of liver enzymes, which is usually always reversible. So if you stop the statin, the liver enzyme goes back down to normal. And this is, again, a relatively rare side effect, probably less than 1% of people on statins. And so far, despite the wide use of statins, there's not been a single worldwide reported case of major liver damage or liver failure from statins. So it's something that is usually monitored for. Your prescribing physician will check the liver enzymes in a couple of months after starting the statin and will watch out for it. The other, again, relatively rare side effect, but is noticed by some people, is a muscle ache or pain in the proximal muscles, which again is relatively uncommon, but is a possible statin side effect.
Okay, great. Next question is, what's the difference between stable angina and unstable angina?
Yes, so that's again a really good question. Stable angina is a syndrome or pattern of exertional chest pain, which is predictable. So if you're somebody who has stable angina, usually you can predict that, after walking 3 blocks or climbing 2 flights of stairs, you'll get this pressure in the chest. You'll sit down or you'll take a nitroglycerin pill under the tongue and it will subside. And usually just sitting down and resting, the pain will go away. This is usually caused by clogging in the arteries, but stable clogging in the arteries. Unstable angina, on the other hand, is a condition where the episodes of angina are increasing in frequency, occurring sometimes even at rest or with very minimal activity, and there's a changing threshold for when you get angina. It's very important to recognize the difference both for the patient and the physician, because the unstable angina is often a precursor to a heart attack. In patients who have the unstable angina, there's often a clot forming on these areas of plaque or clogging, and this clot is activated and it's progressing, hence the threshold of the angina or chest pain keeps changing, and this is often a precursor to a full-fledged heart attack. Stable angina is usually more benign because the arteries are clogged and they have a predictable lack of oxygen when you increase exercise, but they are not susceptible to getting completely clogged or having a full-fledged heart attack. With unstable angina, you should seek medical attention right away and go to the emergency room.
Okay, one last question. At what age should someone start eating a heart-healthy diet?
That's again a great question. We used to always wonder about this. The current position is that it's never too early. The American Academy of Pediatrics actually recommends that after age 2, and they say age 2 because the first couple of years you need a lot of fat to build up neurotransmitters and brain development and so on. After age 2, they actually recommend being on a heart-healthy diet, meaning low saturated fats, more fiber, more fruits and vegetables. That would prevent things like childhood obesity as well.
Great. Well, this concludes our program. Thank you, Dr. Sehgal, for this insightful presentation. It was great having you here tonight. And thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.